Now in this talk, we want to consider preeclampsia. And this is one of the world's common causes of maternal morbidity and mortality. To begin with, we have various types of hypertensive disorders in pregnancy. And today's topic is particularly on one of those disorders of hypertension in pregnancy. But before we get into the meat of this talk, really, I want to differentiate these various types of hypertensive disorders in pregnancy. And the best way to do that, we have a scale of 1 to 40. So here we have the scale, and that way there will be 20 in the middle. So here we have 20 and 40. Now, these numbers represent weeks. So we have the first week of gestation up to 40 weeks of gestation, particularly because a normal pregnancy can go up to 40 weeks of gestational period. Now, how do we classify these hypertensive disorders in pregnancy? The first one is chronic hypertension. Now, chronic hypertension is a type of pregnancy that persists. Sorry, it's a type of hypertension that was there even before the pregnancy. So it can be even before the first week of gestation. And this type of hypertension particularly will go on even after the delivery of the baby, even after labor. It persists even up to puerperal periods. So this is what we call chronic hypertension. And the other one is gestational hypertension. Now, gestational hypertension is also called pregnancy-induced hypertension. And this type of hypertension will only occur after 20 weeks of gestation. The woman didn't have hypertension, but after 20 weeks of gestational period, the woman begins to have signs of hypertension. And the signs of hypertension will be the blood pressure of at least 140 millimeters of mercury, that being the systolic blood pressure, and the diastolic blood pressure of at least 90 millimeters of mercury. Then we have the diagnosis for hypertension, gestational hypertension particularly. The other one is preeclampsia. Now, this is also blood pressure of at least 140 millimeters of mercury, being the systolic blood pressure, and the diastolic blood pressure of at least 90 millimeters of mercury. And in this one, we are going to have protein in urine. So the diagnosis is going to be that with protein in urine. Then we have preeclampsia. So we take the difference between eclampsia and hypertension, which is gestational hypertension. The only difference is protein in urine. In hypertension, gestational hypertension, we don't have protein in urine, but we have elevated blood pressure. Whereas in preeclampsia, we have protein in urine. Now the other one is eclampsia. Now, this is a complication of preeclampsia, because what the word eclampsia really means is convulsive states. So when the woman begins to have seizures, the woman who already has preeclampsia begins to develop seizures, then we have the diagnosis for eclampsia. So we don't want the fits, because this is the most dangerous complication of preeclampsia, and we always want to prevent this from happening. So we don't want eclampsia. Now, I remember myself not understanding this, but we also have the other type of hypertensive disorder in pregnancy, and that is superimposed preeclampsia. I've run out of space here, but it's superimposed preeclampsia in women with chronic hypertension. So the woman already has an hypertension, but after pregnancy, after 20 weeks of gestational period, she goes on and begins to develop protein in urine. So that is what we call superimposed preeclampsia in women with chronic hypertension. Now, having said that, having classified these hypertensive disorders in pregnancy, knowing what we are really talking about, we now move on to our definition for preeclampsia, because this is the main talk that we have right now, and it's for preeclampsia. Now, what is preeclampsia? How can we define preeclampsia? This is a type of hypertensive disorder in pregnancy characterized by protein in urine and with elevated blood pressure of at least 140 millimeters of mercury being the systolic blood pressure and 90 millimeters of mercury being the diastolic blood pressure. And the diagnosis is going to be at least 6 hours apart in 24 hours. Then we have the definition for preeclampsia. Now, what can cause preeclampsia? Well, studies are being conducted. Even up to now, the cause for preeclampsia is unknown. However, we have the predisposing factors to this preeclampsia. So what are some of the predisposing factors to our eclampsia? Now, the predisposing factors are really not the causes of preeclampsia, but these are some of the factors that can predispose the woman in developing preeclampsia. And the first one is age. Now, younger women at least less than 18 years of age, and older women at least greater than 35 years of age, studies have shown that these are more predisposed to developing preeclampsia. The other one is race. Now, studies show that race is one of the most contributing factor to this type of hypertension. So, for example, the blacks are more predisposed than other races. Being obese women are more predisposed to this type of disorder. We talk about conditions such as diabetes also can predispose the woman to developing preeclampsia. Now, they talk about planned gravitas, the first pregnancy, also predisposes the woman to developing this type of preeclampsia, this type of hypertensive disorder in pregnancy. So those are some of the predisposing factors to this type of hypertension in pregnancy. Now, you can also talk about first child with the first partner. Studies are still being carried on about how that affects or about how that can lead to cause or predispose the woman to preeclampsia, but it's one of the most current researches that has come that it predisposes the woman to developing preeclampsia. So those are some of the predisposing factors to this preeclampsia. Now, what can be the pathophysiology for our preeclampsia? Now, pathophysiology for preeclampsia is not well understood. It is still poorly understood because the cause for preeclampsia is not yet known. But there is some of the basic key components that we need to look out for when we are dealing with the pathophysiology for preeclampsia. And that is the placenta. The faults are due to the placental development, and implantation. How does this come about? Well, in a normal pregnancy, the trophoblastic invasion or infiltration of the spiral arteries will need to take place in order for them to gain access to the blood that is coming from the maternal surface. So in order for us to understand this, we do this. So here we imagine we have the placenta here. Sorry, we imagine we have the uterus. And the uterus is in 3 layers. There is what we call the epimetrium and the epimetrium, myometrium, and the endometrium. But in this case, we are going to draw 2 layers. We have the endometrium and we have the myometrium. Myometrium being the muscle of the uterus. The endometrium being the inner surface of the uterus. But in gravid state, the endometrium is no longer called the endometrium. It changes its name to the decidua. So this be the decidua. Now, the uterus is going to be supplied with blood, and the terminal branches of the uterine arteries are what we call the spiral arteries. So these be the spiral arteries supplying the uterus with blood. So these are the spiral arteries. Now, under normal circumstances, the spiral arteries have to dilate, and what happens here is when the placenta, so imagine we have the embryo here developing, and the trophoblastic cells are these outside. So these trophoblastic cells are going to invade, are going to infiltrate the spiral arteries in order to gain access to blood from the spiral arteries. Under normal circumstances, the spiral arteries have to remodel themselves. They are supposed to dilate, they have to change their shape. So this is a spiral artery, and when the placenta is the trophoblastic cells are coming, these are supposed to dilate so that these trophoblastic cells can go inside and gain access to blood, so that the fetus can be supplied with all the nutrients and oxygen that it needs in order for it to grow. That is under normal pregnancy. However, in preeclampsia, these spiral arteries fail to remodel. They fail to remodel, they fail to dilate so that they can give access to these trophoblastic cells, being the cytotrophoblast and the syncytial trophoblast, to enter, infiltrate, and gain access to blood. They remain constricted. Now, guess what happens to this placenta? There's going to be reduced oxygen supply due to reduced blood supply. Now, does the placenta respond? Well, of course, the placenta is supposed to respond. But how does the placenta respond to this situation? Because there is going to be placental ischemia. Now, the placenta is going to respond by releasing certain chemicals into the mother's circulatory system. And those are the inflammatory proteins. So imagine this is the blood vessel in a mother's circulation. They are lined with endothelial cells. So what's going to happen is those inflammatory proteins are going to attack the mother's endothelial cells and damage them. And what do these endothelial cells do? They control the tone of the blood vessel and the elasticity. And what does that mean when those endothelial cells are damaged? Well, of course, the blood vessels are going to remain constricted and they will fail to relax. And that can bring about hypertension. There's going to be hypertension, increased vascular blood resistance. because of the damaged endothelial cells. And as well as that, the endothelial cells are going to increase in permeability. So there's going to be increased permeability. So proteins will be seeping and go into the interstitial spaces. So here we have our proteins. And when proteins seeps, then we know that where proteins goes, even water follows. Now, this is the reason why we are going to have edema. So they're going to have edema in the face, edema in the lower extremities, or edema in any other part of the body as a result of the increased permeability of the endothelial cells being damaged as a result of the placenta producing inflammatory proteins as a result of it being not supplied with a lot of oxygen, because the fault is coming from here. So this is going to happen in all the systemic circulation. Now guess if this is happening at the level of the kidneys are going to be affected. In the glomerular state of the Bowman's capsule, all these proteins are going to seep and they're going to be noticed in urine when we do urinalysis. And that is what is going to bring about protein in urine. Because the fluid, the proteins are going to be seen when we do a urinalysis. Now, if this is happening at the level of the brain, then certain parts of the brain are going to stop functioning, and this can cause seizures or convulsions, which can lead into eclampsia, which we call the convulsive states as a result of the brain not being perfused with blood, certain parts of the brain being infected. Now, this is happening at the level of the kidneys, at the level of the lungs, then the woman is going to have pulmonary edema, and pulmonary edema is going to lead to shortness of breath. The woman is going to have the shortness of breath, which we call the SOB, shortness of breath. And this is another sign and symptom for women who have got preeclampsia. Now, the liver also is going to be affected as well. And the woman can have epigastric pain as well. So all those are the pathophysiology that happens in this person who has got what we call preeclampsia. So the faults mainly are due to the placenta. Now, what about the signs and symptoms for preeclampsia? Well, in most cases, when we're dealing with the signs and symptoms of any condition or any disorder, we tend to look at the three cardinal signs, and we term that as the classic triad. So what is the classic triad for the woman who has got preeclampsia? The first one is hypertension. Now, the first one is hypertension. Now, when we're talking about hypertension, we're talking about elevated blood pressure of at least 140 millimeters of mercury being the systolic blood pressure, and at least 90 millimeters of mercury being the diastolic blood pressure. The other classic triad is protein in urine. This is going to be present. The other classic triad is being edema. So the woman who have maybe generalized edema or edema in the face, edema in the eyes, those are some of the places where the woman is likely to develop edema. Pulmonary edema, and this is going to cause shortness of breath. The woman may have shortness of breath, SOB, shortness of breath. The woman may have headache. So the woman may have headache. The woman may have epigastric pain. So there will be pain in the epigastric region as a result of the liver being involved. The liver may be swollen as well. So we have run out of space here, but for the purposes of making this video short, we are going to focus on these signs and symptoms, but there are a lot of signs and symptoms for the woman who has got preeclampsia. So for example, you can mention hyperactivity, because the central nervous system is involved and the woman may be having hyperactivity. And of course, we may observe that when we are dealing with the deep tendon reflexes. So, in the next talk, what we want to do, we want to start the consideration about the management of the woman with preeclampsia. And I want to point out the certain important concept before we start the management for preeclampsia. And the important concept is the only cure for preeclampsia is delivery of the baby and the placenta. And this will depend on two things. The first one is the severity of the condition to the mother, and the other one is the ability of the fetus to survive in the extrauterine life when we delivered it before its gestational age was complete. And we do this if it's below 37 weeks of gestation. We may give antihypertensive drugs and still keep the pregnancy, and that is if the preeclampsia is not severe. If the preeclampsia is severe, we may proceed with the delivery of the baby. We'll talk about this in a little bit more detail when we start the management for this type of disorder, a well-screened disorder in most clinical areas, preeclampsia.